Next item. I have the pleasure of introducing our medical director, Dr. Alex Rodi. I'm going to read a little bit of his background and what actual medical direction means to the district and the service we provide. Dr. Alexander E. Rodi has worked as the medical director for Bonita Springs Fire Control and Rescue District since, I believe it's 2008. Right? Let's see. As medical director, his qualifications must comply with state statute 64J, which include Florida licensed MD or DO, board certified in a broad-based clinical medical specialty with demonstrated experience in pre-hospital care and demonstrative active participation in a regional or statewide group involved with pre-hospital care. The duties and responsibilities of the medical director involve developing medically correct standing orders, which we refer to as guidelines, to permit specific basic life support or advanced life support procedures when a delay in care would potentially threaten the health of a patient. Additionally, he develops and implements a quality assurance program to assess the performance of EMTs and paramedics. Included in the evaluation of performance of standard of drugs, medical equipment, system protocols, and procedures, and authorizing the use of controlled substance through the Department of Justice, DEA. The medical director also assumes direct responsibility for the use of cardiac defibrillators and the use of airway adjuncts. He is responsible for the instruction of the DOT-approved training programs for EMTs and paramedics, and approving all testing procedures and all assessment tools to certify all district medical personnel to perform medical practices for the public. Dr. Rodi is a board-certified emergency medical physician and a family practitioner, graduating from the University of Medicine of Dentistry of New Jersey Osteopathic Medicine and John F. Kennedy Memorial Hospital rotating internship in 1980. He has been the attending physician's department of emergency medicine at Virtual Health Systems in New Jersey, Hospital Group of Southwest Florida, Cape Coral Hospital, Lee Memorial Trauma Center, East Coast Emergency Physicians in New Jersey, Sacred Heart General Hospital in PA. And currently, Dr. Rodi works as an attending physician at South Bay Hospital, Ruskin, Florida, Physicians Regional Medical Center, Collier County, and Gulf Coast Medical Center, Fort Myers, Florida. Furthermore, Dr. Rodi has performed as a physician clinical instructor at multiple healthcare institutions. Additionally, he performs duties as the medical director for the Cape Coral Police SWAT Team, Southwest Florida Urban Search and Rescue Team, Iona McGregor Fire District, Cape Coral Fire District, and the Bonita Springs Fire District. Also, he performs medical director responsibilities for the EMT and paramedic program for Southwest Florida State College, formerly known as Edison College. Dr. Rodi? He lacks a little experience.
Just a little. I want to say hi to the new board members that don't know me. Always available if you have questions, things you need to talk about. What I would like to talk about is probably something that's not said very much. And it's not said because most people don't really know about it. Having done this for over 35 years, dealing with the public sector, with police and fire, FBI, U.S. Marshals, I see things that the general public don't see and don't know, and sometimes not even the agencies know. I take care of firemen, EMS, and law enforcement in Lee County in a very small practice I have where I do mostly wellness, hormone replacement type of alternative medicine practice. Why do I do that? I do that because our men and women that serve the public have the same kind of stress that somebody serving our country would have in a war zone. People don't understand that. They say, what are you talking about? They're firemen, they're cops, they sit in their cars and do nothing all day long, or they're sitting in the station watching TV. You don't have an understanding for what it takes. As an ER physician for 35 years, you are on the edge as a paramedic, as a firefighter, as a cop. You are on that edge. Your adrenal glands are screaming those 24 hours that you're on call. That alarm can go off at any moment. You got to be able to deal with anything that walks through that door. And you have to show you can deal with it. You have to set a tone that you can deal with it. You may have never seen it before, but you have to know what to do because everybody's looking at you. You're the leader. Doesn't matter if you're a paramedic, the physician, it makes no difference. You're the leader and you have to set a tone. You have to be confident, you have to be decisive, you have to have the knowledge, you also have to have the skill. The problem is when you're off that edge, what do? Where do you go for help? Where do you go to regenerate yourself? You can't bring what you've seen home. You see a child suffer a traumatic injury and die, very difficult to go home and tell your wife about it. Most of the time, they don't understand. Or they'll say, well, you know, I don't want to hear about it. Or they'll say, oh, you're still thinking about that? That was 3 weeks ago. So where do you go to release that trauma that you have, to release that vision that keeps going over and over in your head? I find that that's the most underappreciated thing that we deal with as members of the public sector. And I consider myself a member of the public sector. Obviously, by my CV, you see that I serve a lot in the public domain. And I do it because I like to do it. That's what I want to do, because there doesn't seem to be a willingness of physicians to understand what everybody goes through that does this job. So it's very important to me to be there for them. The job is not one every 3 days. I mean, it may look like that on paper, but believe me, these are professionals. They live this every day, even when they're not doing it. This stays with them all their life. I joked with Chief Daigle and Chairman Lohan. I said, you know, so I think Chief Daigle asked me, well, you've been doing this a long time. Like, you know, have you reached that point where you just can't take it anymore? You only work nights. You work every weekend at night. And Gulf Coast, I'm at Gulf Coast now. I have my own company. That's why you see that I've been in a lot of places. I travel around because I like the change. And I said, no. I said, you know what happens? You get so far burnt out that you come around full circle and it's all new again. And they started laughing, but honestly, that's how you start to deal with it. You know, you realize you love what you do. You cannot do this job. None of these gentlemen or ladies that do this job in this profession do it for the money. They don't do it for the recognition. They do it because deep down inside, in their soul, this is what they love and this is what they want to do. They want to serve their fellow man. You're not going to get rich at it, that's for sure. But what you get from it is something you don't get from any other job in the world. So my hat's off to them. I appreciate what they do. I try to support them. I try to help them, educate them. But it's a tough job. I think the most important thing that we can do as an agency is to have an understanding of what they go through. You cannot do this job 24 hours straight. You cannot do this job without some downtime where you can get away from the noise for 10 minutes, get away from the radio and just get your head together, you know, and get yourself set. You won't last. Highest number of MIs job-related are in who? Firemen. Earliest age of death in what profession? Firemen. So it's not an easy job. Any questions, gentlemen? Anything you
That's
wanna
what I
ask?
have to look forward to.
Yes, sir, Chief. Hey, I'm 61. I've been an ER doctor. You know the average lifespan of an ER doctor in the ER is? 15 years. So I'm unusual, and you know that from dealing with me as the other board members that know me. So
Maybe you could explain to the new board members, I think all the rest of us know, but a little bit about the training and how the buck stops with you. I mean, you're responsible for everything these guys do, so maybe you could talk about that a little bit.
Sure. There's one thing I'd like to recommend to the new guys that don't really know this, that don't really know what goes on, or they may think they do, but they don't. Go spend a shift with one of the guys in the street. Ride in the truck with them. Go to the medical calls with them. You'll see what it's about. And just imagine doing this day in and day out. And think to yourself, well, maybe this day it's not going to be too bad. Or maybe this day we've had 15 calls and it's horrific. I've seen stuff I don't want to see. I'm going to dream about this for the next month. I'd recommend that to you. I'm sorry.
Just the training and how
Oh, yes.
the
guess so.
responsibility involved in what you do.
As the medical director, and this is true for the medical directors throughout the state who do this kind of work, I am ultimately responsible for every medic in the organizations that I work for, which means if they do something wrong or they make a mistake, it comes to me, it comes on me, I get sued. I'm the one that has to answer to the state, to the plaintiff, to anybody else, the regulatory commission, state EMS commission. I'm the one that has to answer to them. So it behooves me to make sure that they're trained above the level that's required by the state, above the level that's required by the county. There's something called common treatment guidelines that the county uses. And this is developed by the county in conjunction. It's supposed to be in conjunction with all the agencies, but in Lee County, it's always been only with EMS, which is unfortunate because we have a lot of really good people in the fire agencies. These guidelines, and I use the term guidelines because that's what they are, they're not standards of care, they're guidelines simply to use by a medic if he's not sure of what to do in a particular situation, he's not sure of the progression of what he's supposed to do. This just helps focus him back on the problem at hand. That's all well and good, but in the medical profession, we call things like ACLS, ITLS, PEP, PALS, merit badges. And most of my colleagues don't believe in merit badges for physicians because you're a doctor. You think outside the box. You don't follow a cookbook of how to treat a patient because patients don't follow the cookbook. You have to assess each one individually. It's incumbent upon me as their medical director to make sure that these guys can think outside the box. Now, is that the way medicine is taught to the paramedics and EMTs? Not up until a year or so ago when I took over at Edison. We're trying to meet the national registry standards for EMTs and paramedics, which is a completely different game than what they've been teaching. It requires a different type of mindset, and in addition, the state of Florida will now require passage of that exam to be certified as a medic in this state and as an EMT. So that's a big change. They're national standards, and there's no book they can pull to learn it from. They have to be able to think. I try to incorporate that mindset change, that education change, into what we do in our monthly lectures. They have obligations to do research, to present a case, to present a lecture, a PowerPoint. It's out of their comfort zone. But you know what? When you're dealing with a public and you're at a cardiac arrest or you're at even just a sick patient, we'll call it, you are in front of other people. You have to learn how to portray and get your wishes across and information across to the people around you, and also to be a leader and to instill confidence in what you're doing. You can't do that if you don't have experience doing it. So I think by doing a presentation, it helps them. In addition, we have cases that we go over. We do QA, but the most important thing we do is when I present them with a case like they were in the field. I'll give them the typical call, and I'll just use an example. You get awoken at 3 a.m. with a complaint of 80-year-old woman who fell. And that's what you'll get on the radio, 80-year-old woman who fell. So I'll say to them, you get in the truck. The fire stations are the most appropriately placed based on the county demographics. You're going to be the first ones there almost every time. And you go to the scene. En route to the scene, give me a list of all those things that can make this patient fall and what are the consequences. What could they possibly have wrong with them? Now you would say, oh, well, you know, in the beginning, they'd give you 2 or 3. When I first started here, maybe 2 or 3 things. And I'd say to them, seriously? That's all you can think of? It's a heck of a lot more than that. Today, they can give me a list of 40 or 50 different differential diagnoses for anything I give them. That's a great improvement. It shows that they're thinking, that they can take a small bit of information like a physician does. When I'm in the ER, it's almost veterinary medicine most of the time. And they can, with that little bit of information, formulate an idea of what's going on and then go through this checklist in their head and eliminate things as they examine the patient and get whatever additional history they get. In addition, we have the 100 top, well, they're called my 100 top drugs, that they have to learn over the course of a year. They get tested on it. It's emailed to them. They have to look them up. They have to know these drugs because a lot of times your patients, they don't know what they're for. They may be on a handful of drugs and they'll say, yeah, I take these. Well, what do you take these for? I don't know. So if you know what the drug is, you know what it's for. If you have a patient who has altered mental status, they hit their head or they're demented and you get called, you can look at their drugs and say, oh, well, he has hypertension, he has atrial fibrillation, he's got diabetes, he's on a blood thinner, oh, he's on a blood thinner, he fell and hit his head, that's not good. This guy's gonna have a bleed. He could be bleeding in his head and maybe that's why he's altered. So this is information that they learn how to use. This is not something that's taught in medical school. We are in the process of developing critical thinking in our labs at Florida Southwestern. It is the change because students don't come to us out of school anymore with that kind of skill. They're not taught to critically think. They want you to give them the paper and, okay, this is the test questions all here. This is what you need to know. That's what they want. They don't want to have to look at it and say, well, why do I have to read that whole chapter? And I tell them, you're responsible for everything in that chapter. Well, why? Why can't you just tell me the important parts? I said, because the patient's not going to come in with 3 of those things. You have to know everything in that chapter. Give you an example, I tell them. When I was in medical school, the professor would come in and he'd lecture on what he liked. Let's say it was congestive heart failure. You have 300 pages of cardiac disease and he lectured on congestive heart failure. What do you think his questions were going to be on? They weren't on congestive heart failure. They were on the other 295 pages that he didn't talk about, but you still had to know it. And in order to be good at what we do, we need to know that information. We need to keep it up to date. We need to continually read, and I encourage them to do that. They get bibliographies with the lecture. I refer to certain textbooks. Unfortunately, textbooks are about 10 years behind. There are certain journals that are good to read, certain types of the merit badge courses I mentioned that are good. Pre-hospital trauma life support's an excellent course. There's a new course that I recommend for all our EMTs and medics to take called Tactical Combat Critical Care. It gives you a whole different concept of how to deal with this active shooter thing, which as a fire agency, you gentlemen are going to be seeing this in the coming few years because we're already doing presentations on this throughout the country. Fire will be responsible for going in and looking for victims. The scene may not be 100% secure, but they're going to have to be tasked with going in and looking for victims, and they're going to have to know what to do with them. And it's not civilian EMS that you do with these people. It's not the civilian medic that you need. You need somebody that understands tactical injuries and how to treat them because they're not the same as what they're used to treating. So these are some of the things we do. It is very intense. We are a fire EMS agency. You can't do 100% fire and 100% EMS. It's impossible. You have to do and balance what you have with your people and the types of calls you get. So we try to divide it up, hitting the critical points, encouraging the battalion chiefs and the training chiefs, which continually reinforce the process with our people. You have to do that. You got to have dedicated training chiefs to do that. I think that that's the best way that it works. Does that answer your question?
Yes, it did. Very well. Thank you, Dr. Rodi.
Anybody else questions?
Anybody have any questions?
Chief, it won't be a problem if the new commissioners want to ride along.
They could do whatever they want on this fire department.
All right. Thank you.
Thank you, Dr. Rodi.
Thank
Very
you,
much.
Doctor.